I am Jimmy Evans, and this is Barbershop Therapy. We cut through the problems.
Barbershop Therapy. Barbershop Therapy. Barbershop Therapy.
Good afternoon, everyone. This is another episode of Barbershop Therapy, and I have three amazing guests with me today. And I'm going to let me introduce myself. I'm Jimmy Evans, the host of the Barbershop Therapy, and I'm here with three amazing people. From my left, I'd like you to introduce yourself.
I'm Herbert Miles. I'm an emergency room physician practicing here in Raleigh, North Carolina with Wake Emergency Physicians. We work out of the Wake Med Health System.
Thank you, sir. Ma'am, and yourself.
Hi, my name is LaTasha Hines. I'm from Kinston, North Carolina. I currently work as a nurse practitioner at UNC Rex.
And last but not least.
My name is Derrick Smith. I'm a physician associate, also working in cardiology with LaTasha at UNC Rex.
And his muscles are bigger than everybody else's. So, thank y'all for coming today. And I think we got some important stuff we really want to talk about. First of all, as physicians, and we're going to jump right into it, right? Can you share, y'all share like your personal journey, how you got here, especially as African-American medical professionals. Give us some of kind of your unique experiences and just share some of the approaches you take to patient care. I mean, Mr. Tasha, we're going to go ladies first today.
I was about to say that, ladies first. So coming into being a provider as a nurse practitioner, of course I started as a nurse first. I've been a nurse for 11 years. Surgical trauma was my passion due to me growing up in Kinston with a lot of violence, gunshot wounds, stabbings. We probably have one of the highest crime rates locally in this area. So I decided to become a nurse so I could help provide quality care to patients. Prior to being a nurse, I actually was a chemist. A lot of people don't know that about me. So I did chemistry for almost 20 years. And I just decided that, hey, I can help people that way, but more so help people on the forefront. I enjoy talking to people. So that journey kind of led me to taking a break for lunch while I was working as a chemist. And I went to Parker's. For people that live in Greenville, kind of know where that is. And there was a couple of older people there, and they kind of just went unresponsive at the table. I was CPR certified at the time, and I just walked over. It was like an out-of-body experience. So once I saved, what I now know is ROSC for this lady, it just kind of gave me the inspiration to help people. So I went from being a chemist to a nurse, and then to being a nurse practitioner. So that kind of helps me to provide quality care to patients that I see.
That's amazing. So you just kind of walked into it literally.
Yeah,
wow.
I enjoy it.
Okay, just helping people. And,
helping people.
Chemistry, what's going on with the chemistry?
So with chemistry, I actually tested different medications. So that kind of helps me now as a nurse practitioner. I have the actual genetic basis as far as how, or the mechanism of action of how medication works in the body. So that kind of helps me to understand and to actually talk to my patients to kind of say, hey, this is why we give you a tablet versus a capsule versus a suspension and things of that nature.
Good. We're gonna come back to that later because that's really important because a lot of people when they get into a hospital situation or urgent care, whatever the case may be, they don't know the difference between a slow release or whatever,
right.
Things of that nature. So thank you for that, and we're gonna get back to you on that. Dr. Derrick.
Not a doctor.
PA Derrick. Okay, my bad. I'm surrounded by good folks. I'm excited.
For me, I always had an interest in science. I wanted to do something that would allow me to be of service to people. So I went to ECU for my undergraduate degree, majored in biology and psychology. And after that, I worked for a little bit as a pharmacy technician, and just was kind of exploring different options where I could go exactly in healthcare. I was initially on the pre-med track, but I couldn't decide what area I wanted to go into, and I learned about the profession of being a physician associate, and just the ability to work in different specialties and kind of easily change within healthcare depending on where my interest is, or it was. And so I worked as a medical assistant for a little bit in an outpatient pediatric clinic. Got a lot of hands-on experience as far as learning how to draw blood and administer vaccinations, do all kinds of testing. And it was also when COVID hit, so I got some experience there in that setting. And then I got into the George Washington University physician and assistant program.
Okay.
And that was a 2-year program. That's where I got my degree. And now I'm working in cardiology.
All right. I know I changed a Band-Aid real good, so y'all are making me feel just insignificant.
Can I ask them a question before
Sure,
you get to
go
it?
ahead, Dr.
So because one of the things that he said is like as physician assistant, he can kind of pick and choose what he wants to do. Have you always done cardiology, or did you?
Yeah,
since
so
you got
I graduated in
Okay.
2023.
Okay, so went right into
I've been
cardiology
in
from there.
cardiology for
Okay.
2 years.
And since you started nurse practitioner, straight into cardiology as well?
I did, and I actually specialize in acute care.
Okay.
So I can work in ICU settings and things of that nature. And I guess the difference is with being a nurse practitioner versus a PA for me will be we can't really switch up our specialties as far as if I wanted to do family practice, I would have to go back and specialize in family nurse practitioner.
Okay. That's all good information, and this is essentially what we're here for, is about this information. Now, Dr. Miles, let's talk about your path to your profession.
So I was born and raised in South Carolina. So growing up, I didn't know any doctors, didn't have doctors in the family, didn't have doctors in the community. My pediatrician was white, so I didn't really have role models that I saw directly that inspired me. But my mother was a school teacher. So my mom did 30 to 40 years in the as elementary educator in the South Carolina public school system. So very early on, she instilled the importance of education in me. She fostered just very early a love for learning. So I excelled academically because I actually loved learning. You know, people didn't have to motivate me to learn. It was something that I wanted to do. And so I kind of figured out very early on, probably 7th or 8th grade, that I was more of a left brain analytical type thinker. So I knew early on that I would go into some kind of STEM field, science or, engineering or some mathematics related thing. In college, I went to did most of my education in South Carolina. So I went to college at Furman University in Greenville, South Carolina, majored in biology, did a heavy emphasis on chemistry too because I love the sciences. And it's kind of, as they both were saying, I kind of knew somewhere along the way that I wanted to do something where I could have an impact in the community, have an impact in people's lives on a personal level. And so just over time, just as I started looking at things, it was just the combination of being an analytical thinker, liking to problem solve, wanting to do something that was based in the sciences, and wanting to have the impact on people's personal lives. Medicine just was the thing that fit for me. So kind of once I got into college, I kind of did an emphasis on the pre-med track, and I never looked back. Went to medical school in Charleston, South Carolina, at the Medical University of South Carolina. And that was really the time where, I was always aware of kind of like, because, my mother, father went to segregated high schools, grew up in the Jim Crow South. So I was always aware of what was going on around me. But it was really kind of once I was in medical school that I started realizing, because I think at the time that I was in medical school, South Carolina was 33% black. Less than like 2% of the students in medical school were black, and as I started seeing the patients that I was taking care of, most of the patients were black. So, that's when I started to recognize that most of the patients looked like me, but most of the providers didn't look like me. And so I went into medical school really thinking that I wanted to do a surgical subspecialty because I just love doing procedures. I love the high acuity stuff. So when I say high acuity, meaning the preventative medicine is important, but the thing that is most gratifying to me is getting in and fixing a problem. You have a broken bone, let me fix that bone. You've got a collapsed lung, let me go in and put in a chest tube. I like fixing the acute problems. So for me, just kind of the being in the office, doing the preventative stuff every day was just kind of not my bag. Okay. So I originally went into medical school thinking I wanted to do surgery, but then as I started thinking, how can I have the most impact on the underserved Black and minority community, where the big need was primary care. But again, like I said, for me, I just didn't really mesh well with the preventative care type stuff.
Would that be boring for you?
That was boring. It would be boring.
Okay.
It was just boring for me because we had to go through all of that. The way medical school works, you do rotations in every specialty. So, you spend a month in internal medicine, you spend a month in surgery, and I just didn't like the clinic preventative care stuff. So, but when I got to emergency medicine, it just felt like the perfect fit because it allowed me to do some primary care because the people who are uninsured and people who don't have primary care doctors, they come to the emergency room for their primary care needs. And but it also allowed me to do the procedures. So that's how I ended up in emergency medicine.
All right. Well, listen, those are all impressive stories and parts of how you got to where you are currently. So just moving a little further into that, could y'all share some of the challenges that you might have faced, and also, some of the things that might have motivated you to even go even further and not, succumb to the challenges? As we're gonna do, ladies first.
So I feel like there's a lot of challenges there. First of all, just being a woman, period. It's really hard, and a Black woman at that. It's really hard to.
Okay, I'm sorry.
Absolutely. Being a Black woman, it's really hard to be in a predominantly white world. I mean, when I look around, there aren't providers like me. And when I say like me, I say I'm LaTasha, and I always say this, I'm from Kinston. A lot of my patients, they kind of relate to that. Okay, so you aren't this uppity provider who walks in a room and yells all these words out that I don't understand. No, I go into the room who I am. When people see me, hey, I'm Tasha, I'm from Kinston, I'll be your provider today. Oh, you gonna be the NA? Oh no, are you can you take me to the back? Absolutely. So I always tell people it's hard, not the information. I mean, anybody can learn. And I would say this, it's not, a lot of people say, oh, you had to be smart to be a nurse practitioner. You had to be smart to be a doctor. You don't have to be smart, you have to be determined. You have to be dedicated. You have to think about what it is in life that you want to do. If you want to play a guitar, it takes dedication. If you want to ride a motorcycle, it takes dedication and practice. So it's just like that coming into the health field, it just took practice. And like him as well as I can say for me, growing up, we didn't have a lot of Black doctors. We mainly saw white physicians. My mom, she has a high school degree. She married a long time ago to my father, who was in the military. So back in the day, you grew up and you were raised to, hey, women, we grow up, we tend to the house and the kids, and we get married. So going into a field and knowing that, hey, people depend on me. They need me to be smarter than smart. They need me to be above and average. No matter what, I have to strive to be better than I was the second before. I can't just be complacent. A lot of my counterparts can get their degree, and that's it. And they get the raises, the patients listen to them. The patients you can say, hey, you have diabetes, you need to take this. Oh, okay, we'll take it. When I go into the room and I look at my Black patients, diabetes, what's that? You mean sugar? Oh, okay, well, I didn't have a donut today. Well, it just doesn't mean eating donuts. But you also have to think about, too, when you are underprivileged, you don't have the means to buy the healthy foods. You don't have the means to go to the best hospitals. And a lot of times when you are, I would say, the best providers, or what they consider as the higher educated providers, they send you to like the best facilities, right? Because a lot of doctors, like, you have to put in bids to be accepted to actually work in those places. It's just like us as nurse practitioners. I mean, I applied to over 20 jobs before I got the job that I have now. However, but I was experienced and been at a facility for 11 years. But how would my counterparts take me now? Because I went from nurse to now nurse practitioner. I went from, hey, you are the little black nurse, to now black nurse practitioner. How can I take that from you? I can't take orders from you, but I could take orders from a white NA, or I could take orders from, a white doctor. So it hurts internally, but I take that and I push it with strive, and I look at it like this. I will never be defeated with the comments or the mannerisms or the actions of my patients or my counterparts, because I'm there to help them. So I put aside, and when we take this oath of providing unbiased care, that's what I do. That's important to me. Unbiased care. When I walk in, whether they're white, blue, purple, green, or yellow, that could be my mom, that could be my dad, that could be my grandma who's 100 years old. She taught me resilience. So when you go into a room and you feel like you're the only person, like now, the only female here, I stand tall and bold, because I know that behind my blackness is education, and nobody can take that from me, and that's important to me to help my patients.
Man, did you get all that? That was right on point. So that goes to some of the challenges, right?
Right.
What are some of the highlights that kind of help you push through and be like, this is why I'm here?
Honestly, I take it back to my grandmother. Like, if she can make it to 100, I can make it through anything. So the challenge really is making sure that my patients know what it takes to live a good quality life. When I think about economics, I think about education. Those are big challenges. You can give a diagnosis, but do your patient truly understand? So how do we educate them? How do we make sure that they know, hey, I have sugar, but what does that mean? I've noticed a lot of people, even working in cardiology, we think about hypertension, we think about cholesterol, we think about diabetes, but do we send them to a dietitian? Do we do these consults to make sure that our patients can not only survive here in the hospital, but when they get home? Do you remember what we talked about? Do we call these patients? Do we have hotlines where these patients are going through a crisis, even if it's like mental health? Do we have like a diabetes crisis hotline?
I don't think
Do we have a heart failure hotline? Somewhere that when they're in the midnight hours or the morning, early morning hours at home, and they're not feeling well, and they say, I don't want to go to the emergency room. I'm going to sit there for 8, 10, 20 hours.
Right.
And then all they're going to say is, go to your primary care. I go to the primary care, I pay this copay, and the man comes in for 5 seconds and say, yeah, you still have diabetes. Okay, you've already told me that 20 minutes ago, 20 hours ago, 20 years ago, but hey, I done lost my toe. Now I'm losing my left leg. My hair is not growing right. My fingers are falling off. But you never told me that all this could happen. Oh, I did. I told you you had diabetes. I told you you had uncontrolled hypertension. But I never set you up to succeed. And I think that's the biggest thing. We don't follow up. We don't follow through. We get you through that, like he said, the acute phase. And then we push you on to the next physician or the next PA or the next nurse practitioner.
Okay, so what I'm hearing from you right now is that there needs to be more clarity.
It does.
There needs to be more education behind what the doctors are giving to the patients, from your estimation. The ability for people to understand the terminology.
Absolutely.
And giving them a better quality of life and possibility of a longer life.
Absolutely.
So that's a wonderful thing that keeps you moving to motivate you to keep on even when it gets a little difficult. A similar experience with my mom in the hospital with just a lack of empathy in the moment at times and the ability to they were very detached in the moment, and not on the same page in multiple occasions, from the attending physician in the morning to the attending at night, and just not very organized. So I appreciate you bringing that to light, as far as like the motivation behind why we need to do better as a community and teach each other, and having like doctors and practitioners of your kind right now is really important to get this information out the way that we are. Dr. Derrick, PA Derrick, could you share one of your challenges and some of your motivations as well?
Yeah, absolutely. So I think one of the challenges we all have is that, this profession, this country, this world tries to put us in a box. Black people are a monolith. They see us and they make assumptions about, how we talk, what we do, what we're interested in. And that's a challenge that I've had my whole life. And from being a kid to undergrad to PA school to work now, people see me and they expect that my interests are X, Y, and Z. They are surprised.
I did that to you.
It happens. It happens. And some of the challenges that I've had are, when I walk in a room and let's say I have white patients, it's like they're holding their breath a little bit because they first they're either expecting me to be maybe an orderly transporting them somewhere, or something like taking their tray, and then I tell them I'm with the cardiology team, how are you feeling? And then there's a pause as they wait to see if I actually know what I'm talking about. It's something that I see all the time, and my challenge has been just trying to break that mold that they try to put me into, whether it's patients or colleagues or whatever, because when people set their expectations, then there comes judgment, but one of the things that has been rewarding is when I walk into a room and I have black patients, I see that relaxation and
Excellent.
yeah, that makes it so much easier to just engage and know that my presence is a sigh of relief for them.
That's right.
And I think that one of the challenges that I've also seen as a provider is that we have patients who they end up at the hospital, whether it's in the ED or they're a direct admission or a transfer from another hospital, and they've had something that's been going on, like a chronic condition that they've been dealing with, but they've lost interest in addressing it, and they just want the patch, so we can try to have the conversation about, what you can do to prolong your life, your quality of life, but they just want us to patch them up and send them on their way. And I understand, the frustration, the fatigue, getting a hospital bill, having somebody lecture you, I get that. But I think what they need from us is a moment of empathy, as you were talking about, to show that we care about not just discharging you, but making sure that you're not coming right back. And then I think that if patients saw more of that, it will make it easier for them to invest in themselves and start thinking when they're at home about the habits that they have, or even just the thought that they have about their health, in order to have better outcomes. I think that a lot of things that you were speaking about how you like the high acuity situations. I like getting in the conversations about preventative measures. You know, the kidney failure that we see in your 60s, that was due to the kidney disease in your 50s, and that was due to contributed by the diabetes in your 40s and the high blood pressure in your 30s, and then the bad eating habits or lack of exercise in your 20s. And so I think that if we could address that pipeline and start helping people think more forward, you know, that could be leading to better outcomes.
Okay, but that's another that all great points, and just leading to building up trust, right? And relationship to your patients. And I think that's one of the things as African Americans, you know, we done heard about all of the Tuskegee experience and all the other things and that have happened at the behest of medicine. But, you know, seeing somebody that looked like me when I walk in there is a definitely a level or a sigh of relief, like, all right, they're gonna take a little time, they're gonna listen, because talking to a lot of other practitioners that aren't black, they give you that what do you call it, churning out patients on a 15-minute rotation. You got 15 minutes of my time. How's your blood pressure? How's your cholesterol? How you got a headache? You been breathing? Did you stand up this morning? Okay, good. I'll see you later. Come back in 6 months. Without the patient knowing how to just say, hey, wait a minute, but I've felt a lump, or I've been having bad headaches, or my sinuses, or my heart, but they kind of get rushed out of it. So, you know, Mr. Dr. Miles, I want to get your intake on that.
On
just the motivations and the challenges that you know. I know we talk about a lot of the problems, but we got to talk about the problems to get to the solutions, then to get to the motivation.
Okay. So I think as minority healthcare providers, we kind of all have faced a lot of the same stuff, so I can echo a lot of what they have already said. I think probably the biggest obstacle for me was just, it just seems like no matter how much you prove yourself, people still doubt you. And I'll tell the story, not to toot my own horn, but like a prime example. So I graduated valedictorian of my high school. But despite being the top person in my class, you know, when the white high school counselor was counseling all my white classmates on going to college, she was counseling me that I should go to trade school.
Wow.
You know, so, and I'm the top guy in the class.
Wow.
So I ended up going to college. Like I said, once I decided that I wanted to do pre-med, my best friend from college was also pre-med, black guy from Augusta, Georgia, and he's a cardiologist now, practicing in Texas. But we were the only two blacks in the, so I don't know if any of you know Furman University, but it's a predominantly white university, founded by the Southern Baptists. I went there simply because I got a scholarship, you know, and my parents didn't have the money to pay for school, so I was looking for the most affordable way to get my education. Right, so, but we were the only two blacks in the pre-med program, and again, you know, I saw all through college, like all of the white pre-med people were, you know, getting appointments set up quarterly to speak to the person who was, you know, the counselor who was in charge of the pre-med program. Who spoke to me once in 4 years, you know. So we just didn't get the same counseling, you know. They were, like I said, getting quarterly for 4 years. So, you know, so just every step of the way, you just saw that. So when I finally went to med school, so again, I applied to several different med schools. You always apply because, you know, it's competitive. You don't know where you're going to get in. I got into every place I applied. I decided, okay, I'm going to leave South Carolina because I originally wanted to leave South Carolina for undergrad, but again, I stayed because at the end of the day, I said I'm getting a free education by going to Furman. So I said that makes sense to spend money going elsewhere. So I said, but I'm going to get out of South Carolina for medical school. So I had gotten accepted. The way medical school works is they send you a letter, you've been accepted, offered a seat, but then you're on the clock. You either got to accept it or not because it's competitive and there's a lot of people on a wait list. So if you say, hey, thanks, but I'm going to decline the seat, And, that's what I did with the Medical University of South Carolina because I had my mind set that I wanted to go outside of South Carolina. So, like in the final hour, I get a call. This is like 2 or 3 weeks after I had declined the seat at the Medical University of South Carolina. I get a phone call from the dean of the School of Medicine. He introduces himself. He says, "Hey, I'm looking at your application file, and we really want you to come here." He said, "We just started a program. It's brand new." He said, "But the reason we started this program is because of applicants like you." He said, "We got a lot of really bright students in South Carolina, but most of them leave the state. They end up going to Duke, they end up going to Vanderbilt, they end up going to the big name schools. We want to keep the top talent in South Carolina." So he said, "So this is the first year we're doing the program." And he says, "And we're only offering 2 candidates a year. The qualifications are we have to think you're the best candidate in the state and you have to be from South Carolina, but you get a full ride to come to medical school. Will you come if we offer you a full ride?" So I ended up at MUSC. But I tell that to say, so now these people gave me a scholarship because they thought I was the best candidate in the state. 2 years, second year of medical school, I'm at the top of the class. Literally, I walk across campus, people are like whispering and looking at me because that's the black guy that's at the top of the class. There's never been a black guy that ever graduated at the top of the class at MUSC. He gonna bring, so I mean, it's like, what did you expect? You gave me the scholarship because you thought I could do this, but now it's like, you're waiting for me to fail. So, those were the kind of obstacles that I just kind of faced all along the way. It's like you say, even though people could see it was like you say, it was more like waiting for you to fail instead of expecting you to succeed, So those were kind of the obstacles I faced along the way. And like I said, you just saw it at every level. I remember my first job. So when I finished residency, I worked in Georgia, a little small town, Albany, Georgia, for 4 years before coming to Raleigh. And I can just remember there, so they hired 4 new doctors and 3 of the 4 were black. And before they hired us, it was eight doctors. They were all white and they were all above the age of 60. So, and that was pretty much the demographic of most of the doctors on the medical staff. So they just didn't, that was just unfamiliar to them in small town Southwest Georgia to have 4 young black doctors all under the age of 30. And so nurses would write us up for nonsense, Like I remember, and I'll explain this. So there's a medicine called droperidol that it's an antipsychotic medicine is what it was marketed for, but also works very well for migraine headaches and works very well for nausea and vomiting. So just to give you examples of what would happen is like, for example, one of the black guys who was Jamaican wrote for droperidol because he had tried every other vomiting medicine and couldn't get the patient to stop vomiting, gave the droperidol, which worked. But the white nurses would write him up saying, "Oh, he's giving antipsychotic medicines to patients that don't have psychiatric disease." So we would just always, face stuff like that. We were always getting written up the most, and so just you see it at every step of the way.
So what pushed you through those moments like that?
So for me, it's always the patient interactions because, as he said, you walk in the room with a black patient and they're happy to see you. And there's been so many times, like, after I've had an interaction with my black patients, it's not even the patient. It can be, for example, I could be taking care of the wife or the mother, but before I leave the room, the husband's like, "Brother, before you leave, let me just say I'm proud of you," and those kind of interactions, they make it worthwhile, and even though I like the acuity, I'm 100% with everything that they said. I spend more time than anybody in my group educating my patients. And so the thing that's most rewarding to me is probably at least twice a month that a patient will say to me, "I've been dealing with this problem for 3 years. I've seen 6 doctors. You're the only one to ever sit down and explain it to me in a way that I can understand it." And so when I have those kind of interactions, it makes it all worthwhile and just helps me push through.
Okay, with that, man, listen, we're gonna I gotta soak all that in first. Good gracious, that's good stuff, right? So the thing now is I kind of want to shift gears a little bit and talk about the improvement of care in minority and patients and partnership with the hospitals and things of that nature. What, based on your experiences every day, what specific things would y'all like to see change, whether it's policy, whether it's communication, whether it's culturally, and I'd like to see amongst you what that conversation looks like right now. Anybody feel free to jump in, because that's one of my biggest things is to see what changes for the better.
So I'll start, and I'll say that I think first and foremost, we have to get more providers that look like us, because you mentioned policy, but you just can't legislate away unconscious biases, because a lot of the things that we see that lead to the disparate healthcare that minorities see is unconscious bias. I mean, we know there are overt racists out there, but it's very rare in the medical setting that you're going to see a white doctor just overtly say, oh, I'm not going to follow the standard of care because of your color. Most of the time it's unconscious biases that's, causing disparities. Prime example in the emergency room. There have been studies, and again, I'll talk on the emergency because I'm in the emergency room, but there have been studies, for example, that show if white patients come in with pain versus black patients that come in with pain, and particularly black women, the black patients receive less pain medication. So if a white person comes in saying, Doc, I'm having abdominal pain, you might be in the emergency room for 3 hours, because by the time I get blood work, by the time I get a CAT scan trying to figure out what's going on. So white patients are much more likely to get pain medicines in that 3-hour period to address their pain while the doctor's trying to figure out what's going on, whereas black patients are less likely to get it. Now again, in most cases, it's not the doctor overtly just think it's unconscious biases. And it goes way back. You talked about stuff like the Tuskegee experiment, but there was a time where doctors thought black people didn't feel pain like white people did, and so it's deeply rooted stuff, but those are the kind of unconscious bias things that you can see. There's been studies that show, for example, we're not supposed to treat a minor without the consent of their parent. There's a few exceptions for that, but in most cases you need the parental consent. There are studies that show that if you look at which minors should come to the emergency room and are assumed to be adults, it's usually the black young females, So there's just these unconscious biases that, that just kind of the way that drive care, and it's hard to legislate that away, because basically what we see in the healthcare system is just a microcosm of society at large. And so until you can learn to get people to be more culturally sensitive at large, it's just really, you have to do that through education. You have to do that through sitting down, having conversations. People have to be open to having conversations with people who, from different backgrounds,
So how often does that happen though? From that standpoint, when we're talking about changing, policies or whatever, or cultural education, where does that conversation start if it doesn't start with the administration and things of that nature in the hospitals or in the doctor's offices? Where does that change come about?
But that's where it has to start.
Okay.
That's where it has to start.
Y'all got any thoughts on that?
I think it starts there, but I think like Dr. Miles said, you can't change a person's perception, their mind state, because we read policies all the time. Every hospital has the cultural policy. You have to be culturally competent, right? But what does that really mean? Can I really teach someone who's not black how to understand my root, the way I was raised? How, and I say my grandma, she's 100. Can I really teach you the things that she taught me, and for you to understand if you've never walked in those shoes? And when you read a policy, it always says, be mindful of what you say around people. But are people really mindful? Do they really think about what they say, or do they just speak because here it backs up to that. Like, what are the disciplinary actions when it comes out? Can you prove that what I said was offensive? Could you prove that when I walked into that room, I didn't want to take care of someone who was black? I mean, I can prove it. I can show you. I know your actions. I've worked with you, or I've watched you take care of African American patients. But, I mean, it's hard. And then when you don't feel good, do you really all the time understand that those providers have some kind of culturally unbiased towards you? You don't know, because you don't feel well. And I also look at, like, I thought about for myself, like, I battle inappropriate sinus tachycardia. But I saw some of the best cardiologists at UNC Chapel Hill. And I was in school working and doing, but I was always told it's anxiety. You have anxiety. Oh, it's anxiety. And to the point where they'll make you feel crazy. So you have to be very mindful whenever you're talking to people and you think about, like, when you say policies. I don't think a policy is going to change a behavior unless you're able to call that behavior or prove that that behavior is truly the effect on the patient. And it's hard to prove, because I can read my note. I mean, clearly the doctor said, oh, she's very anxious, she's this. No, my heart rate is 180 and I'm sitting here dizzy and lightheaded and I feel like I'm gonna pass out. And I've spoken that to you. I've relayed that information to you, but in your mind, when you came in, it was already, oh, she's a little black girl, she's in college, she's stressed out. Where's her support?
Just
I said,
exaggerating.
yeah, sir, I have support, but they can't support me in a medical condition that I don't know what's going on. And now we know that, COVID has caused a lot of these things, and now that this stuff is coming back. So do I go back to this doctor and say, hey, it took me 3 more years, but now that I have somebody who was culturally aware, and they actually took away the fact that I was a little black girl, and they said, let me actually look at the data. And now they're actually able to put me on medication. Do I go back to that doctor and say, hey, it wasn't anxiety? Like, you need to be culturally sound. You need to just take the culture away and actually treat your patient. It's not going to change unless people actually become culturally aware and know that, hey, I need to check myself before I go into this room. And I'm here to help and not to actually cause more problems, or I'm here to listen. But it's just hard. That's what I found. It's hard.
How does this conversation help change that narrative, right? How do we take this information and get it in the right hands to say, hey, we have 3 experienced people here that truly understand culturally, financially, health care, insurance-wise, where the gaps are to change people being heard versus talked at.
Right.
I agree with Miles. I think we definitely need more black people, more people of color providing health care for patients. But we also have in addition to providing health care, in addition to that job, we have the job of educating our colleagues. And I'm not saying we have to have seminars or monthly meetings or anything like that, but when we hear those innocent microaggressions, those biases, it's our job to say something. And whether they hear that and change, that's on them, but it's our job to speak up for our patients in that way, to address that incorrect thinking that our colleagues or staff or whoever is exhibiting. And that kind of will help to change, I believe, the culture as well, in addition to more people representing the patient population.
Okay. Do you feel that extra pressure to be the one correcting that because of maybe your superior will not recognize it because he doesn't look like us, or you're just being sensitive, Derrick? That really wasn't that bad.
It's definitely an added weight because we already have the pressure of just looking after the patient, making sure the patient has the best outcome, and you don't always feel like getting into a conversation because somebody said something that they weren't thinking about, or they were showing where their heart really is. But if we're looking for long-term change, if we're looking for better outcomes for various populations, that's the burden we gotta bear. I think that it varies. I think it depends on how you approach it. You know, for me personally, I benefit from people putting me in this box. I don't think anybody can call me sensitive, but so I do feel a little bit more confidence in addressing things. But yeah, it's an extra obstacle in addition to everything else that we have.
So is
And
there
I would add this, because you said, how does this conversation help? The one thing I would say with this conversation, particularly as it pertains to black patients, you need the white people in the room. Because like I say, right now you're preaching to the choir. We're, like I say, most of the times, like I said, the people who are going to be the most culturally insensitive are the people who don't look like you. So, right, because it's not, so those are the people, you need those people in this room to be involved in this conversation.
Okay. So what I'm hearing is we definitely just can't keep this siloed.
Absolutely.
It has to be a mature conversation with people that really want to make change, opposed to like a lot of the legislation that's out there right now is about keeping things status quo. Just adding to where we are, I guess that kind of moves us into that next space of, the advocacy and self-protection. Like, we talked about it earlier, with the meds and as a chemist, how the reactive substance act with the body and things of that nature. A lot of people just don't know that when they go in and talk to their primary care doctor. So I guess the question is, what advice do you give, your patients or their families when, especially maybe taking care of their elderly family members when they're in the hospital, or your wife or your child, what's the best way to conduct yourself when you're not confident in the care that's being given at that moment, in emergency room or even hospital stays. How do you address that without coming off as the angry black person in the room? And anybody feel free to jump in, because I've been there again. As a 12-year-old boy, got my leg popped and my knee twisted. Emergency room doctor stood in between my legs and pulled my leg back into place with no anesthesia, no nothing. And
What's that? Black people less likely to get pain medications.
and I'm 12 and I'm literally punching this dude in the back of my head, in the back of his head, trying to get him off my leg. My leg today is still not straight because I probably tore ACL, all that other stuff, but he don't feel enough pain. He's laying here, he's fine. I'll just pop it back into place real quick. And so my parents didn't know no better. They stood right there and they were like traumatized themselves. So they were almost speechless in that moment for me. But I'm sitting there like, man, I don't ever want to see a doctor again in my life. I might start karate kicking them as soon as I see him. So what do we do in moments that and talk from both sides of the fence as physicians, nurse practitioner, PA. I'm frustrated with the care. How do I present myself without getting kicked out of the hospital? Or as the doctor or attending physician in that moment, what do y'all see to help facilitate that moment and make it amenable for both parties? Anybody?
I think that from a patient perspective or a family member advocating for a patient, it's easy to get caught up in just wanting somebody to come in and say, I know what I'm doing, this is what's going to help, and just go with whatever they say. But I think that as a patient or someone advocating for a patient, you need to think about, how do I avoid getting back here? How do we make sure that we are on an upward trajectory as far as our health and quality of life. And so when you're thinking about that, if your healthcare provider is saying, we're going to have you do physical therapy, or if they don't even say anything about physical therapy, you ask, physical therapy, if they're in here and they're not walking right, how do we get them walking how they were before? If they are saying, we're going to start you on this medication, it's like, well, what does this medication do? What side effects can I expect? How long will I be on this medication? Is there anything I can do to decrease the frequency or the strength of the medication that you're telling me that I'm going to start? And then as a healthcare provider, I think that it's important to go in with empathy, meet your patient where they are. You know, it goes back to treating your neighbor as you would want to be treated, and just put yourself in their position. And you know, we can tell the patients that they want to ask something, but they don't know how to. And you know, it's just taking that extra time to are there any questions, anything you're concerned about? And a lot of times they'll think of
They'll
something.
figure it out.
Yeah.
You know, because patients and their families, I think a lot of practitioners don't do a good job of guiding them to the answers that or the questions that they need to ask. They are very stern in their viewpoint of what the situation is. And I'll give you an example. My mother was in the hospital with pancreatic cancer, and we were checking her in there for an upper GI scan, and she passed out. And so it was a foreign doctor. He came in, we got up on the table, and she hadn't been eating for almost 2 years, a little over 2 years. She's just been eating like a bird. And you know, this guy looks at her, and first time he's seen her, you know, oh, you have to eat, you have to eat. Man, what do you mean? We know that. That's not, you're not saying anything. And he was very matter of fact about it. And so, you know, that turned me into, you know, crazy son. Well, hold on, partner. Who you think you're talking to? First of all, I'll leave you in this hospital. But it'll take you there because he clearly didn't want to understand the full problem. He didn't want to understand what she's been through, and nor did he take the time to ask myself or my father, you know, hey, really what's going on, so I can understand what's going on. You already assessed that she's the problem. And so, you know, in those moments, you know, I almost go to jail. So how do you address those type of physicians that treat you as if you're the issue?
So, I mean, I think, like you said, as Derrick was saying, a lot of times I can sense when a patient is not pleased. And if I do sense that, I'm not going to ignore it. I am going to say, hey, Mr. Evans, seems like you have more questions, or it seems like something's on your mind. Is there anything further we need to discuss? But the doctor is not going to always sense it. But one of the things you said was, sometimes the providers don't do a good job of helping the patients to know what questions they should ask. That's because we see a wide spectrum of patients, okay? And I see patients that come in that have PhDs in chemistry, and so I start explaining medicine. Oh, doctor, you don't need to explain that to me. That's what I do for a living. I understand all the medicine. I don't have any questions about the medicines. Like I say, I have some patients that I come in, like you say, I tell them she got diabetes, and she said, first of all, how I got diabetes? I don't eat sweet stuff, you know. So you have to meet the patients where they are. There's no way for me to know what questions I need to guide you to, because I don't know where you are in terms of what you already know or what you don't know. So I think that, you know, being an advocate for yourself or for a family member, you have to ask the questions. You know, if you have questions, you just got to speak up, you know, and that is the doctor or the nurse's job, you know. And you're absolutely right. Sometimes it feels like, hey, they're just trying to run me out. But hey, if you have to, hey, nurse, could you, whenever the doctor has time, I need him to come back in the room. There's some questions that I need answered, you know. if you have time, you don't always, but in a situation like your mom's where you had been dealing with it for a little bit, do what you did. You talk to me. Hey, what questions do I need to ask this doctor when I go in here? This is what's going on. So if you've got resources like me or Derrick or to ask, because we can help you to say, hey, well, man, if this is what's going on with your mom, when you go in there, we had the discussion, man, ask them about this. Ask them, is this an option? Ask them. But for people who don't have those resources, try to do some education yourself about your condition, because at the end of the day, a conversation is always a two-way street. And so I can't hold the conversation on my own. And so, prime example, and I'm sure they hear this all the time. Patient comes in to me and, well, doctor, I'm having chest pain. Well, you ever had any heart problems? I saw a heart doctor 3 years ago. Well, what did he say was wrong? I don't know. He did some kind of test and put me on some kind of medicine. Well, what medicine was it? Oh, it was a little blue pill. I don't remember the name of it. That's not an effective conversation, because I can only educate you and further the conversation if you can give me the information that I need. So I would say to advocate for yourself or for family members, you have to be as knowledgeable as you can about and that some of that is getting knowledge from the doctors. When you go to those doctors, is ask the question, doctor, what is the diagnosis? What is the next step in treatment? What is the medication? What are the side effects of this? And if mom or dad has some cognitive problems they may not remember, you remember it for them, But if it's a first visit, hey, well, let me I know the doctors told me I got a prostate issue. Just let me just see what I can do research on my own so that maybe I can go in prepared at least to have some questions in mind, because like I said, it's just going to be impossible for us to direct you to the questions you need to ask, because everybody's, level of education is going to be different. Everybody's condition is going to be different, and the questions that they have are going to be different.
Great point.
Great
point.
If I
Yes,
can just
absolutely.
jump off that, I would like to say to patients that there's no question that we as providers will feel is an inappropriate or stupid question. If it comes to mind, share it. And that's what Miles was saying. Just we don't know where you are. When you share whatever you're thinking, that helps us educate you to be there for you, to better advocate for you. So just have that in mind whenever you are interacting with a healthcare provider. Also, if you're in a hospital setting, if you're worried about, you mentioned the example of parents with cognitive issues, memory issues, don't feel like there's a question that we as healthcare providers can't answer. Like if you're concerned about parents remembering to take medication, ask us and we can talk about social services, things like that, to help get your family member, your loved ones on the right track. In the hospital, we have contacts that can help line things up for the best possible outcome.
Great.
And I guess I just want to piggyback off of that, because to me, when you say as a family member or someone who's advocating for their loved one, or as the patient, speak out of a place of love. Even when you're frustrated, just say like, hey, this is frustrating for me. Sometimes it's not what you say, but how you say it. So you also got to think about, and I take this back to COVID days, we were the essential workers, right? We stood on the front line to provide care for our patients, even when there were daily viruses. A lot of people lost their loved ones in healthcare. I'm not saying out of healthcare, yes, but a lot of providers died, right? People out of healthcare had the chance, the opportunity to stay home. They didn't have to come out and interact with people, but we did. We were mandated to get the COVID vaccine. We had to do certain things to stand, to be where we are today. So to me, that alone gives us a level of respect you should have for your provider when you come to the hospital or to your doctor's office. So my thing is, don't go into it already saying, well, when I get there, I'm going to tell them this and I'm going to make sure, and I've been sitting in this waiting room this long. Your composure alone sometimes dictate how we feel when we come in the room. We can feel the tension. So then when we say, okay, everybody, me, because this is who I am, hey, take a breath. Whew. All right, that's over my little introduction. I'm Tasha, da-da-da. Now, tell me what's going on. Tell me what you've been going through. I know you told doctor such and such, hey, I'm a nurse practitioner, not a doctor. I don't know everything. But tell me, explain to me how you're feeling. Don't use medical terms. I just don't feel good. What does that mean? Then I can prompt you. Then I can kind of relate to you. Then I can kind of, but if you're yelling and screaming at me, I can't hear you.
That's right.
I can't even process what you're saying. And as far as the different resources, we have a lot of resources. And a lot of times as a nurse practitioner, as a PA, as a medical doctor, we might not know all the resources. But we have case management, we have social workers, and they know it. But we don't know your need if you don't tell us. So I think that's where the collaborative care comes in. We depend on the nursing assistants. We depend on the nurses. We depend on transport. We depend on these people to tell us what the patients are saying in that moment. Because it's crazy, because I might be scared of Dr. Miles. Like, I can't tell him. But then I see Derrick and I'm like, oh, he cool. He look like somebody, a homeboy from back, da-da-da. But look, when the doctor came in, I didn't understand this, but you're here now. Honestly, I smoked crack, or I've had patients do that. But the doctor just asked you, were you having chest pain? Do you currently smoke crack? We know it's in your chart. Or do you snort coke? Oh, no, I don't. But now, because you feel more relaxed, because maybe it was a different connotation. Maybe you just didn't want to see, him as a doctor. But now you see somebody else and you might open up. It's up to us as providers now to collaborate that care. Go back to Dr. Miles and say, hey, I don't know if they told you, but yeah, they still smoke, Yeah, they still doing this, and that's probably what's causing it. So I think it's just it's just a revolving door. Like, you have to treat, like Derrick said, you want to treat people the way you want to be treated. And if you feel like someone is not treating your loved one right, that's the moment to say, hey, not in a stern tone, even though you feel it, but take a moment and say, hey, I don't think that's the best way to address her, because she's not even going to understand what you're saying in that tone. Now, if you don't want to treat her, or if you don't feel like you can speak to her in a nicer tone, then hey, let me get someone else. There's plenty of doctors on call. There's plenty of hospitals. There's plenty of primary care that you can seek and you can be a part of, but don't be afraid to make that move. Don't be afraid. Don't think that that is the only place you can go. You can go anywhere. You have insurance or not. Emergency room doctors cannot turn you away because you don't have the insurance to pay. If you don't feel good, go be seen. And I think that's the key. A lot of people, you guys don't feel well, but you will not come be seen, because a lot of our patients say, I haven't been feeling well for a long time, but I knew I couldn't afford it. Even if you pay them $1, 50 cents, whatever, just come be seen. And what you don't know is there's programs out there for people who are uninsured that the social workers can put you on to help get you the care you need.
Okay. But look, thank y'all all for all that insight. And I'm probably the one that's going to be yelling at people when I get frustrated, because I don't know how to use my words.
You've come to this podcast, so now I know that you know better.
So I got all the information. I don't have an excuse.
No excuses.
So what I'm hearing is it's a collective, right? And there needs to be a team effort to make sure this happens. If one provider's not able to articulate or get the information out of a patient, then it's the team that comes in.
Absolutely.
There's the whole rotation of everybody that's coming through that builds that trust, that builds that has that somebody might not have, some doctors may not have the best bedside manner, but their PA or their nurse practitioner or their RN has that bedside manner that gets that information, out of that patient that needs to be relayed to the doctors. And then to the resources.
But let me just throw one more thing in, because one thing I would say, just to address your specific situation when your mom was in the hospital. So a lot of times in the inpatient side, particularly with something going on like what was going on with your mom, they're going to be, because you mentioned it seemed like there was no communication between the daytime attending and the nighttime attending. A lot of times there are going to be specialists from different services involved. Okay, so your mom might have been seeing an oncologist. Your mom might have been seeing a gastroenterologist. And one thing to understand is each of them is going to be focused on their specific problem. Okay, so the gastroenterologist is going to deal with his gastroenterology issue. He's not going to necessarily have information on the oncology part of the thing. Likewise, the oncologist is going to be very focused on his oncology part of the treatment. He may not know completely what's going on from what the gastroenterologist has planned. Your mom passed out, let's say they thought it was something with her heart. They consult cardiology. Cardiology is there specifically to figure out, hey, did she pass out from a heart condition? We're not dealing with any of the upper GI stuff. Somebody else is having it. So, but usually there's going to be a hospitalist or somebody who is kind of the captain of the ship. So what I would say in situations like that, particularly where you're feeling like, hey, there's one attending coming in and another coming in and there doesn't seem to be communication, ask your nurse. Ask, hey, there's a lot of different people coming in. Who's kind of the captain of the ship? Who's the person in charge here? Because usually there's going to be a hospitalist or somebody who has the whole comprehensive care plan, kind of, understands all of that. Like I said, because, if you're going to because I don't know if it was the gastroenterologist, whoever was going to do the upper GI study, but like I said, if you're expecting him to kind of understand the whole, it's just not going to happen in a situation like that where your mom's been hospitalized dealing with, this chronic ongoing thing. So if you can try to identify the person who is in charge and kind of, coordinating all of it, you might get more answers that way.
So I think that was my frustration in that moment. There was that person wasn't there.
Okay.
And so we had to actually go to the administrators of the hospital to facilitate that person coming into that moment, because that was, again, the most frustrating point was to watch 3 different segments of doctors come in, like you said. You got the gastrologist, the cardiologist, and I can't think of the other one right this second.
I think she was seeing the oncologist, the cancer doctors.
Oncologists. And they were not communicating with one another and giving medications that were not conducive to a positive outcome until we went further to the administrative measures and got the president of the hospital down there. Right. And so I think when people understand, and thank you for sharing who that person should be, and if you don't mind looking in that camera and telling them who that person is, that again, right there.
Yeah, so usually if you are hospitalized and being seen by multiple different specialists, usually the primary physician who is coordinating all of that is the internal medicine doctor, who is called the hospitalist. So usually they are the person that's going to kind of know the entire comprehensive care plan. They're going to be monitoring the input and the feedback and the recommendations of all the different specialists, and that's probably going to be the best point of contact for trying to get most of your questions answered.
All right, thank you for that. Y'all got anything y'all want to add to that? This is getting good, getting all emotional over here. I'm feeling tingly. This is good stuff. I want to move on to our next segment of questioning, and it's more about preventive health care priorities, particularly for Black men. From an intake standpoint, when we go in for our regular physicals, or I'm not feeling well, what are some of the tests that maybe should be prioritized once you come in? I'm 55 years old, going in, I'm feeling a little sluggish. I don't got the zest in my step that I used to have. What would you suggest as practitioners to look at initially from his blood work, or what type of tests would y'all have?
Well, let me just seek some clarification, because for us as medical professionals, when we say preventative health care, you are not having symptoms. Preventative health care is you are not having symptoms, but we're doing screening stuff to try to catch things early. So if you come in to me saying, I'm feeling sluggish, and to me that's not preventative health care. At that point, we're investigating some active symptoms that you're having. So are you asking more like
let's go
just a routine preventative health screening, or are you saying the workup of, hey, I'm feeling sluggish. What are we doing here?
Let's start with preventative.
Okay.
And
start
then we'll
with
work
prevent-
our way up to.
Okay, so
you
we're
being
starting with
sluggish.
preventative
We'll talk about me later.
Okay.
But preventative health care.
I'm
Okay.
trying to get some free
What
advice
is that?
now.
Okay.
Why you calling me out
Free
in front of
advice?
everybody?
No free advice today.
Have some water.
So we're talking about, so the question
No free
is,
advice today.
what types of things should you be expecting to be done for
Yeah, just a
preventative
workup
health care?
for your, the 45-year-old checkup, the 50-year-old, the 60-year-old checkup.
Okay.
Because a lot of black men go to the doctor, and again, whether you're feeling bad or not, just as a checkup, what things should we start looking at, like your prostate,
Gotcha.
your heart, your high blood pressure, your things of that nature. But are there other levels of testing when we start talking about hormonal? And we don't think about men's hormones changing and going into different spaces, and so what kind of test would you suggest, just off a basic workup to elevated workup?
Want me to start? You guys
Yeah,
can start.
go ahead.
So there are things that are, no matter what kind of group you break people up into, whether it's by nationality or race, gender, there are things that people are predisposed to. So, starting with the patient, you need to know what are you predisposed to. Right now we're talking about black men. So, we know high blood pressure, we know diabetes. These are things that when you go to your healthcare provider need to be on the forefront of your mind. And, I was talking about earlier, the diseases that we're seeing in our 60s, the foundation for those were laid in your 20s. Okay, so I would say as a black man in your 20s, first establish primary care somewhere. Make sure that you're getting checked out yearly, and I would say you pay attention to what your blood pressure is. Okay, you get an understanding of what is normal blood pressure for your age, for your overall physical condition. Keep an eye on that. You also need to know your family medical history.
That's important.
If you've heard, an uncle had a heart issue, ask a few more questions. If mom has high blood pressure, that's relevant. These are things that play into your health. Also in your 20s, you need to be getting screened for sexually transmitted diseases and infections. Like, those are the things that, even though you feel fine, and you might even think, I don't need to have a checkup, like, those are things that you need to be keeping an eye on, just to be proactive in your health. You go into your 30s and you're looking at those things as well, but also throw in your cholesterol. You're checking your cholesterol. You're also doing that in your 20s, but your 30s, you're looking at that. You're looking at the diabetes screenings if you have the family history. If you have family history of prostate issues, you're going to start looking at that then too, and then pretty much continues into your 40s, and then you get the colonoscopy there.
That's good sleep right there, though. That's
And once again, that you want to know what your family history is, because if you have a family history of colon cancer, that screening is going to be sooner than your 40s.
Absolutely.
And I can go through all the years, all the decades, but it's just keeping a priority of being on top of your health when you feel good, and also knowing what you're predisposed to, what your family history is.
okay.
And then to add to that is oral health. Make sure you keep your teeth checked, clean, and in good health. Bad teeth can lead to heart problems and a lot of other problems. Patients become septic and have no idea it came from a bad tooth. That is important. I will stress it again. Make sure you keep your teeth health priority going through these phases as well.
I'll add to that, and I will start even younger. So preventative health care starts in childhood, immunizations. because that's a big thing when we talk about distrust of medicine in the Black community, and we all know what all the debate that went on with vaccines with COVID, but the big part of preventative health in childhood is getting your child vaccinated. And even in childhood, children should be getting like vision and hearing screenings. Like I said, my mom was an elementary school educator. The number of kids that got diagnosed with learning disabilities, they couldn't hear, right? So so you should be getting even kids should even be getting regular like vision and hearing screenings, because hearing and vision is so important during those developmental years. So it should even start there. And then the one thing that I will mention, that because as far as cancer screenings is often overlooked because it starts at such a young age, because we always think of cancer as being a disease of old age, which it for the most part is, but the one exception is cervical cancer in women starts very early. So it's actually recommended that women should start getting screened for cervical cancer at 25. And then, as we said, in case if there's a strong family history, should even be sooner than that. So that's the one cancer that we should recommend getting screened for at a very early age. That should start in the 20s for women.
So you mentioned things that are overlooked. What screenings do y'all see outside of the basic stuff we just talked about, high blood pressure, the cancers, the prostate, colonoscopy, and STDs? What are some of the more advanced things you should start looking for? And I know it depends on your age and your gender and things of that nature, but can y'all kind of give me an idea? So
that's going to be like kind of patient specific, because one of the things you mentioned was like hormonal screening. We don't do routine hormonal screenings. Now, everything is patient specific in terms of, so for example, we don't recommend cancer screening in every patient, but if you have what we call more than a 20-pack year history of smoking, then it's recommended that you start getting screened for lung cancer at the age of 50 with the CAT scan every year. Now, again, family history is everything, because you don't have to be a smoker, but if you say, my mom had lung cancer and she wasn't a smoker, and my uncle had lung cancer and he wasn't a smoker, you probably need to be screened for lung cancer. But again, we're only gonna usually recommend that for people who have risk factors. It's not just gonna be something, because you always have to weigh the risk benefits. So a CAT scan is radiation exposure, and radiation itself can induce cancer. So if you're not a high risk person for lung cancer, we're not just going to say, start at age 40 getting your CAT scan of your chest every year.
Time out. So what you just said, read the label before you get a CAT scan.
Yeah, this is radiation exposure.
That it's a cancer causing product.
Can be.
Okay. All right. I'm sorry.
No, this is true.
Like, a lot of people don't realize that. Like, my father has had lung cancer, prostate cancer, and metastasized to brain cancer. And he has been exposed to all of these tests, and not knowing that could have contributed to some of the, after all the tests. Like, I didn't know that just now. Thank you for letting me know. But it is information like this, like, these not little, but huge nuggets of information needs to be disseminated in our community a lot better, so we know how to, again, advocate, prevent, be self protect, all of the things that we're talking about right now, because unfortunately healthcare is getting worse. They're not paying. The premiums are getting higher. The cost to go, the insurance company's not paying as much money, so we're being subjected to, having to pay absorbent amount, or the ghost bills and things of that nature. That's going to be on the next podcast. But I just really want to, like I said, just get this out to people. And lastly, and to move forward, because I'll get stuck on a tangent, is just building trust and access, right? Trust in the healthcare system can be difficult to establish. That's just what it is. Just a little redundancy, but both for patients and providers to help bridge the gap and ensure African American communities receive fair, respectful, and effective care. I think it goes back to what we talked about earlier. What do y'all think about it? Anybody jump in?
So I think there's definitely more distrust of the medical system in the black community. I think it's well founded, and so I think to start establishing the trust, first physicians and healthcare providers have to acknowledge that the mistrust is valid. Okay, because the Tuskegee experiment, it happened. You ever heard of Dr. J. Marion Sims?
I have.
He's considered the father of gynecology. Did surgical experiments on black women without anesthesia. In the 1920s, there was forced sterilizations of Native Americans, blacks, mentally ill people. So we have to start as providers with acknowledging that the distrust is valid, okay? And then we just have to start having these communications, because if you have these conversations with me outside of the medical setting, then you're more likely to trust me when you have to engage with me in a medical setting. So I think this kind of community outreach stuff that you're doing helps. But like I said, everything is a two-way street. So at some point, the patient is going to have to, if the provider acknowledges that, if the patient is going to have to meet halfway. And so what I mean by that is, I can have your best interests 100% at heart. I can come in the room with empathy. I can sit down and have the conversations and all the things that we talked about that you want. I can answer all your questions. But at the end of the day, if I say, well, Mr. Evans, this is what's going on, and this is the treatment plan that I think is going to work. It looks like you have a pneumonia, take this antibiotic, and if you're going to start saying to me, I don't like taking medicines, I ain't sure I think y'all be putting something in these pills. At some point, you have to be open to engaging and meeting me halfway. It can't be all on the providers. It has to be a two-way street.
Okay. With that being said, as the patient, how can providers build that trust and believing they're gonna get the correct access? Like I said, we got to meet you halfway. I got to come in with an open mind and be honest about what I'm saying and what's going on. So how do we educate more from the client side to how we can get in and articulate our needs to our providers? That I think that's the one of the biggest things that I see is people just don't know what to ask, and then when it get down to whatever their particular situation is, then we're lost in a space of, well, he didn't tell me enough. Well, you didn't ask enough.
I think that as a provider, it's easier for me to kind of get into the weeds of things with patients when I know that they are invested in their own health care, and they are interested in learning everything that is going on. There are some patients I would take the time, but they don't want me to talk to them about stop smoking. They don't want me to talk to them about drinking or eating better so that they can lose some weight. And if that's not what they want to hear, I'll try. But if they don't want to get into it, I can't force them to listen. So I think that as a patient, the best thing that you can do is look to your healthcare provider and tell them, I want to get better. I want to have a long and fruitful life. Tell me what I need to know. I think that's.
And I think that what he's saying is just echoes back to what we were saying before. We're not going to know where we need to meet you unless you communicate with us, because as he said, some people want the full Doctor, I want to know every side effect of this medicine. I need to know every treatment option before we go this route. What tell me treatment options A, B, C, D, E before I choose one. And then you do have those patients who you want to explain things, but doc, no, they don't want. Doc, just do whatever you, doctor. You don't need to explain all that. Just prescribe whatever you think. So everybody is very different. So you have to speak up and let the doctor know what it is you want to know so that they can meet you where you are.
Okay. Man, this has been really good. I think if we could, I'd like to have each of you, leave a parting remark to, what's important to you, and give us about, quick 2 minutes of what you think your people need to hear, and it'll kind of segue us into, doing something on this level again. If you don't mind. Ladies first as always.
So my ending remark will be more so to patients, don't be afraid to know the unknown. Go to your healthcare providers. If you're not feeling well, prior to not feeling well, get those preventative checkups, learn your family, find out who has what, mom, dad, brother, sister, and pay attention. Living a normal life is great if you can actually have a good quality of life. Also know that we all have a time to expire, of course, but we definitely want to leave a lasting impression here on this earth. So don't just go off of, well, I'm gonna just keep drinking and smoking and partying until I go out. And if that is how you want to do it, then hey, as a provider, we don't try to change who you are. We just want you to have the best quality of life. So it's okay to go in and say, hey, I'm not gonna stop smoking. I might stop eating this, but I'm not gonna stop smoking. So my thing is, be who you are, but be that authentic part of you at all times, even with your health care. And we as providers, we support you no matter what, but we are here to educate you and to give you the best resources. And don't be afraid to speak up for yourself, speak up for your loved one, but always remember to speak out of a place of love.
So I'll just piggyback off of Renee and make a final comment about the advocacy thing. And it's going in a little bit of different direction, but particularly I would say for patients who are advocating for family members, one of the things that I would encourage is know your family members' desires, because at the end of the day, when you are being an advocate, you want to advocate and make the decisions that your mom would have made had she been capable of making those decisions herself. Because so many times we get into situations where mom is at a point or dad is at a point where he can't make decisions anymore. There's 3 family members all wanting to be advocates, but this person wants to do that, this person wants to do something else, the third person wants to do something else, but nobody is really thinking about, well, what would dad have wanted if he could speak for himself? What would mom have wanted if she could speak for herself? So I would just say that would be my final comment on advocacy. Like we said, educate yourselves about your condition or your parents' condition, but if you're advocating for someone else, to add to what LaTasha was saying, do it out of a place of love, but also understand, do it and try to respect what they would want done. Don't make the decisions that Jimmy wants done if you know that mom would have wanted something differently.
Very true.
Well, before I say my final words, I appreciate you inviting us to have this conversation.
Thank
It's been
you.
really good. I also don't know if I need to say I'm not representing my employer. This is based on my
Yeah,
education
let's put all the disclaimers out there.
Yeah. But the last thing that I would say, I think, would be to patients or providers, move in empathy. Love your neighbor as yourself. Go to the person where they are and engage in that way. And I think we would have better outcomes across the board, whether that's in a healthcare setting or just interacting day to day. I think that's what's missing mostly right now.
Amazing. Thank you so much. This has been one of the, I think, best podcasts I've done since I've started this a few years ago. And I really appreciate all of you coming in, taking the time to open up, share some things about yourself and about the profession that, this, so we can see you as human beings first and people of compassion that really are here for our community. So thank you.
Thank you for having me.
Thank you for having us.
This has been another session of Barbershop Therapy. My name is Jimmy Evans, your host. Also, I'd like you to like, subscribe, leave comments. If this was good content for you, if you got something out of it, tell us what you want to hear at a later date, and we'll try to get it on for you. But you could also support the Barbershop Therapy Foundation at barbershop-therapy.org, which is also part of our mental health advocacy. For now, this is Barbershop Therapy. We cut through the crowd.
Barbershop Therapy.